Unfortunately, interoperability is not enough. Interoperability in healthcare data between clinical systems and even interoperability of healthcare workflows between clinical systems will not break the market forces that hold back innovation in electronic healthcare records. Interoperability between clinical systems will not bring down the high barriers to entry and the high switching cost associated with the medical record marketplace. And although introducing big tech companies into commercial medical record markets will add new vendors, it will not fundamentally fix these dynamics which lead to a stagnant marketplace. And so ultimately, interoperability not just between clinical systems, but interoperability between functional components of a clinical system is required. And that's what the topic of today's post is. So let's understand why interoperability between systems is not enough. A lot of the focus today is on interoperability between systems, moving information from the hospital to another hospital, from the hospital to the clinic, from the clinic to the patient. And the sharing of information shouldn't be by fax or PDF or mule, but in a format that can be consumed and ingested by the receiving clinical system. And so this has meant the creation and using of standards to exchange patient data. This is a process many decades in the making, but finally it's happening, and there's been definitive increase in the uptake of FHIR and other consumer market forces which have helped drive forward the sharing of patient data. And there is, in addition, an effort, although it's far less adopted, to take interoperability between systems a step further, to allow to not only share patient information, but also to be able to share workflows. For instance, an order could originate in the medical record being used in your doctor's office, and then it would pass seamlessly into the medical record system being used in the nursing home. And you can see more information about this by looking into FHIR workflows. And both of these steps towards clinical system interoperability are very important and very long overdue. However, interoperability between clinical systems is not sufficient, in my opinion, to break the EHR marketplace out of stagnation and to develop the innovation required to really advance healthcare. And so let's take a step back and understand why progress in electronic health records has been slow. And if you ask different people, you'll get many different answers. But specifically, in today's post, I want to highlight that innovation has been hindered because of the size and scope of electronic healthcare record software. Major EHR systems for inpatients or outpatients perform a number of functions: patient care, medication coordination, billing, scheduling, and the sheer number of things that an EHR does makes it difficult to switch to a new clinical system. Switching is time-consuming, it's expensive, and the systems are deeply integrated into a facility's other system, making it very difficult to change. And the other problem is that the broad number of features that a single EHR vendor is able to provide is very hard to build out if you're a new competitor entering into this EHR marketplace. The EHR legacy vendors have been able to build up their feature arsenals for many years. And so if you're a new company, it's very hard to compete directly against the offerings from legacy vendors. Now, even if you were able to, let's say, be a new competitor and enter the marketplace and compete directly on the feature sets available, who would buy from you? The established hospitals and clinics want to purchase software with confidence, knowing that the vendor and manufacturer will be around and can support the software in 5 and 10 years' time. Often it's because that's how long it takes to pay off a lot of these contracts, and also just the thought of having to change systems before that time increment is far too painful. And so to summarize, ultimately, EHR marketplace is hard to enter. Once you're there, it's tough to compete. And this is because of the high pain point required in switching clinical systems. And this is partly why when traditional EHR vendors compete, they don't actually compete directly on quality. And they instead compete on things such as market share, because there's the well-known expression that no one got fired for buying IBM. And so the equation which you can draw from this is that you have high barriers to entry for this market, and you have high switching costs. And the combination of high barriers to entry and high switching costs means you have low innovation and low energy in the market. Well, some may say that won't big tech or won't Amazon fix everything? And if the problem is that if the problem is that healthcare systems won't purchase innovative healthcare information software, because as we mentioned, they want the company to be around, perhaps this Amazon, Berkshire, JP Morgan health venture is actually extremely exciting, because what it does is it provides a sandbox and the necessary environment to make progress in health information systems. Now, with the combined 1 million employees between these companies, Amazon can develop new health information systems that they can use for care delivery on their own patients, essentially their employees. They're able to, in this case, act as both the developer and the customer of that medical record software. And this gets around the problem we mentioned above before of who would buy from new vendors. And I suspect actually that given Amazon's distributed employee base, that they'll probably target outpatient care as their primary area that they tackle. However, will the entry, or actually it's the re-entry, because most of the major tech companies have previously been in the health record marketplace, but will the re-entry of large tech into the medical record marketplace actually fix the problem of EHR stagnation? And I don't think so, because all it will mean is that now instead of having traditional large EHR vendors competing to sell large clinical systems, we'll have now large EHR traditional vendors competing with big tech companies still to sell large clinical systems. It's a stepwise improvement in increasing competition in the marketplace, but it's not a logarithmic improvement. We're still selling large clinical systems, which means that we still have high barriers to market entry, high switching costs, and we still haven't changed this equation, and therefore the result is still low in innovation and a low energy market. And this is why interoperability of data between clinical systems does not fix the equation, which leads to some unfortunate conclusions. Although interoperability between clinical systems is long overdue, and we need to get to a place where patient data can flow easily between hospital clinics and patients, unfortunately, the interoperability of data alone, and even the interoperability of workflows between systems, will not fix these underlying problems which we've discussed about the EHR marketplace. It's too hard to enter the environment, and the switching cost is too high. And unfortunately, the introduction of big tech into this marketplace will add some competition but not fix the broken marketplace dynamics. In addition, interoperability doesn't address a few other big questions. One, how do we integrate efficiently, seamlessly, all the thousands of health startups who are all doing their own thing? How do we actually get this into clinical systems? Or do they just get all wiped out by large vendor systems who eventually acquire them? The other question is, we don't have a clear pathway on exactly how machine learning algorithms are going to be integrated into clinical care for research and then eventually later for purchase in clinical care. And interoperability in of itself doesn't really provide the necessary innovation we need in healthcare delivery systems. Ultimately, what we need in the long run is very tight integration across multiple different clinical services and systems, not just the sharing of workflows and not just the sharing of data. We need an interoperability and a connection which is a level deeper than this. And so the question is, how can we fix this problem? How do we fix this broken marketplace? Unfortunately, as I've suggested, interoperability isn't the answer. In a future post, I would like to suggest one option, which is that we need to decompose the monolith that is the electronic health record into individual functional components and create standards between how these functional components interact. And that will be the topic of a future post. Of course, if you have any thoughts, complaints, criticisms, or feedback on these ideas, I'd love to hear. You can reach me at the bottom of the blog post for my email.